services, then they have incredible success with these patients. Here's the results from ours. We ran into some problems because San Diego pulled their paramedics off because they needed to put them on the street. They didn't have good enough response time, but they were doing even better than that for quite some time. Alameda, this was the city of Alameda, and these patients would freely move around the county, so their results weren't quite as good. But some of the programs around the country are seeing 50–60% decrease in 911 calls, which means similar decreases in transports to the emergency department and visits to the emergency department. We have an interesting project down in Ventura where they're collaborating with public health to give directly observed TB therapy. Now, the reason they do this, they aren't replacing the community health workers who do it out of the TB clinic, but the paramedics can go anywhere in the county, where the community health workers are more limited in their range. It's a big county, and they can go after hours. So they can find these people and reach them whenever they're home and get them to take their medication. So they have an incredible rate, and we're not, like I say, we're not trying to replace community health workers. It's just, and this is more, I see this more as not to prove that they can give directly observed therapy as much as that they can do public health collaborations that can be of value. This was very interesting. The hospice support, when you all know that with patients with hospice, frequently the family or the patient freaks out and calls 911, ends up going to the emergency department, even though their wish is to be treated at home. And so what happens here is because they call 911, 911 can dispatch a community paramedic instead of the regular paramedic, or the regular paramedic, if they went out there, can then call in the community paramedic, and they evaluate the patient, work with the family, calm down the situation. If they need to give meds, remember they can give narcotics, and they call the hospice nurse and discuss it with them. And sometimes the hospice nurse subsequently arrives, other times they manage over the phone. But what they found is pretty remarkable, that they could decrease transports to the emergency department from 80 to 30%. And so this is a collaboration with hospice. Now, the nurses and the hospice agencies are opposing, in general, being able to implement these projects more widely because they think they're being displaced. But there's no way they could do this without the hospice, without partnering with the hospice programs. Alternate destination mental health is happening in Stanislaus County and is about to start up in some other jurisdictions, including San Jose and Fresno. But what they're doing is that instead of, right now, a mental health patient has to go to the emergency department for, quote, medical clearance before they go to for psych evaluation. Well, you all know what happens in that nice, calm environment in the emergency department and how long it takes for them to get their clearance. So what they're doing is they're doing the medical screening. Paramedics are doing the medical screening in the field by protocol. And if they meet the criteria, there's a bed available at the participating psych center, crisis center, they take them directly to the psych crisis center. And so the big question is, the worry is, well, how many patients are bumped back to the emergency department? Actually, it was quite few. It was all of 9 patients over 2 years, and none of them were admitted to the hospital. They were all subsequently evaluated and discharged. So this is what the results look like, and so what you find here is that these are the ones that we enrolled and transported. Okay, there's others. This was ones where they couldn't transport them because there either no beds, or in this case, the wrong insurance type, because remember there's a private hospital and they weren't allowed to take the private patients. And then there was some of them were just ineligible. They had the exclusion criteria, but they're up to well over 1,200 patients or 1,300 patients now with the same pretty much results, and it's working out very well. The police love it because they're not stuck now with these 5150 or psych patients. Now this, like I said, this is a relatively new one that started up in San Francisco, but it's about to be duplicated in a few other communities, which is taking intoxicated patients to a sobering center. This is primarily in the inner city, an intercity program. And again, they're doing screening in the field. They did go to a sobering center where there's a nurse, and they're managed. But not only do they have a bed and a shower and everything is sobering center, but they have social workers to try to get them into detox programs or long-term programs. And again, this is one where they had very few secondary transfers to the emergency department, and really had, it's been working very well. And it saves, and I don't know an emergency department that I've ever heard or seen of that really enjoys having the intoxicated people in the rooms and the hallways. And this bypasses the need for that. So you can imagine it saves a significant amount of money. I talked about the urgent care. I won't go into that any further, but it was because they kept rerouting the patients. So, well, what's the use? This isn't working. They won't do things that they're capable of doing. They didn't have the diagnostics, on and on. So in conclusion, what our evaluator has concluded is that, yes, specially trained paramedics can provide services beyond their traditional scope. And what we're talking about as scope is really no new procedures. It's just where and when they can practice. We're expanding their role, not really their technical scope of practice. And that there has not been any we don't have a single adverse outcome from all these patients. We don't have a single death or a single major adverse outcome. And we have not displaced any health professionals, despite our most rabid opponent for this is I'm sorry to say, is the Nurses Association, CNA. Although CNA has been fully responsible for 2/3 of the health workforce pilot projects in the past, they will not accept anyone else expanding their role. And I didn't show you, but I think you can, this kind of group could easily envision the savings that can be yielded by both health plans and hospitals when we're preventing admissions, preventing transports, and preventing emergency department visits. So I'm going to stop there, and we'll hear from Jimmy Pearson, who will give you a more first-hand account of one of these projects. Yes.
And Dr. Backer, could you say just a little bit more about those striking statistics for UCLA dropping by, what, 3/4?
They did have great results. Unfortunately, the UCLA project voluntarily closed down, but from lack of funding and resources. But they were getting some very good results, as is Solano here, which you will hear about. Do you have Solano?
I'll just mention the importance of that to the public health department, because we have a CHF work group in Los Angeles, and what we've identified is that statewide, about 23% of CHF patients are readmitted, and in Los Angeles it's 29%. So seeing that beautiful reduction is even that much more meaningful there.
So what I should say before Jimmy takes over is there are 2 pieces of legislation currently pending this year to allow us to enable this outside of these workforce pilot projects, which are set to expire in November. One is AB 1795, which is just alternate destination. All it does is enable alternate paramedics to take people to psych centers or sobering centers instead of emergency departments. So it corresponds to 2 of those. The other bill, which is SB 944, enables all of the existing projects. It has some issues from the EMS standpoint, but from the public standpoint, again, it would allow all of these kinds of projects. And by saying allow, it means it would open up the door for local communities or health systems or hospitals to partner with EMS agencies to meet the needs in these categories.
Right. Excellent. Thank you.
Hello everybody, again I'm Jim Pearson with Medic Ambulance. We're in Solano County. We're a family-owned and operated business. We started in 1979, with grandparents and uncle actually. We're a big family, a lot of time families should have the mics because I use my hands a lot. But we're CAS accredited. It's a national accreditation for ambulance services. There's only 180 in the country. We're ACE accredited, which is an international dispatch accreditation. We do about 52,000 calls a year. We travel 1.8 million miles. We are big Highway 80 fans. We do about 80 emergency vehicles and 285 employees. And we operate mainly in Solano County, but do have Sacramento Division as well. So in Solano County, we're a HRSA designated medically underserved area. We had historically high readmit rates. Our use of 911 was being, inundated, not as drastic in some of the urban cores, but we saw it coming up. And when the pilots came out, we were actually approached by Kaiser. We have 2 Kaiser facilities in Solano, Vacaville, and Vallejo. They approached us and said, hey, what do you guys think about doing this concept? It sounds pretty cool. And at that time, Texas and Reno just got awarded about $13 million from CMS to try these concepts. So we said, hey, let's try it out. And as we talked about all the regs earlier, we're in the middle of a trauma battle in Solano County at the time. So our county legislators said, we'll approve it, but we want all our hospitals, obviously, to have the opportunity to play. And so at the time when we submitted to the state, Kaiser, North Bay Healthcare, ourselves, and Solano EMS Agency had signed on. We have a steering committee comprised of local physicians, nurses, case managers, EMS medical directors. Our medical director, who's Paul Kila, has been a part of this from day one. So one of the big goals that we had, and I'm not going to get there, I had a bunch of other slides, but Dr. Backer perfectly talked about all the setup. But one of the big things we did discuss about Solano, which is a little bit different, is we talked about sustainability. We didn't want the pilots to run out and then go, we invested all this money and time, and then it didn't work out. So we had the kind of uncomfortable conversations at first, because there's a lot of money being put up by the EMS agency, in terms of the ambulance agency, and we wanted our hospitals to have a little bit of skin in the game. So that's why there's just us in North Bay. So us in North Bay Healthcare is who went into the pilot starting in September. We do have a fee-for-service model. I can tell you right now it's not a big dollar amount, but it does help us cover the cost. So the nice thing is that if these pilots were approved tomorrow, we actually have a sustainable model to move forward. It's kind of exciting for Solano County and our patients. So the goals of our pilots in Solano was to reduce readmissions, 30 days post-discharge for COPD and CHF patients, and obviously improve the overall health and disease process understanding. So right now, these patients are identified by North Bay Healthcare complex case managers. They score them out, and then they pass them over to us if they feel that they're better served by us going to see the patients. One thing I saw earlier, heard about, is we can work with home health. Currently in our Solano pilot, we don't. When we talked with North Bay's chief quality officer really wanted us to stand alone to measure value. So when they enroll them to us, they get a front line, essentially, like I said, scoring overall, where's this patient at? Then they're referred to us and they're not touched by anybody else. So these patients don't qualify for home health. The patients we're seeing in our pilot do not meet the qualifications for home health, as per the complex case manager at North Bay. So we schedule at least 2 visits. We do that within the 30-day window. And we do a home assessment, we do a health improvement survey, we do a discharge instruction survey assessment, we do a med-rec, vital signs, weight, teach them how to do dry weights, all the kind of fun stuff that we can do in a visit. So we started seeing patients, as I said, September 2015. 281 patients have been referred to the program. 184 were enrolled, 100 being COPD, and 84 being heart failure. 363 visits were conducted so far to date. So this is our current data. We've had 13 unplanned readmissions for any reason, which is 7.1% readmit rate. And for heart failure and COPD specific, as the reasons they readmitted were at 2.7%. So the other reasons are pneumonia, that somebody fall and break their hip. And then also, we classify them as unplanned readmissions too. And that's why I think In the San Francisco slide, it was like 8%, but I'm not sure how we're classifying that. But we had one patient who was a heart failure patient. The doctor moved up their open heart surgery by like 15 days into that 30-day window, so they obviously readmitted. So that's why we classify that as unplanned readmission. Enrolled at the patients do readmit. Patients do readmit. So this is another kind of data we dive into the numbers and see exactly where we're at. When the patients do readmit compared to our cohort group, the patients who were eligible but decided not to enroll, when our patients readmit, they readmit for 3 days on average less. I thought that was kind of an interesting number. Also, we utilize the emergency department about 7 or 8% less than patients who aren't in the program. So they still go to the ED, so about 20% did go to the ED, but they didn't get admitted. And this is just, everybody loves a bar graph, right? So it's just kind of gives us a visual of what it is. So this is how we survey our patients. We do it's an international survey, EQ 5D3L. It's a health score. Essentially, it gives us the patient. If you understand patients really think, I mean, you all understand patients, I'm sorry. These patients show the difference sometimes because it's new for us in terms of how we interact with them. A lot of these patients either think they're very, very sick and dying. We had one patient who thought he was the only patient who had heart failure in the entire world, and that it was over. That's it. And so we did just the basic disease process education, brought that patient back, got them feeling good. And a lot of these patients actually rate themselves really healthy when they're not. So it's kind of figuring out that balance. But we do a self-health assessment, a discharge question understanding, which has actually been good for the hospitals. The hospitals, we work with North Bay on this, and it's actually been a big improvement to North Bay in their discharge process. And over this period of time, I'm not saying we're the reason their CHF and COPD readmit rates have gone down, but they were at 26% when the pilot started. They're down to 16% now for the same 2 disease processes for patients who aren't in the program. So we're working together with them, and we're finding gaps and where they're missing things where we can interject and maybe better educate somebody during that discharge process as well. One of the big things we did, because we knew this would have a lot of eyes on it, is we grabbed a third-party survey company. I know you guys do that, but in EMS sometimes we don't do it all to the levels of the hospital, but we grabbed EMS survey team, and they actually phone call all of our community paramedic patients. We use them for our regular transportation, but they don't phone call. But for the community paramedic, they actually phone call. And out of the 180 patients, they've talked to about 40% of them so far, which is a pretty good, kind of measure of how we're getting that data. And they're rated #1 overall in the country in terms of patient satisfaction score. They're rated about 5% higher than our regular field paramedics in patient satisfaction. So I thought that was pretty interesting. So some of our in-home findings, we spent a lot of time in steering, in setup, in the year up to training, on focusing on the paramedic bag, what's in the toolbox, what they did. And it's really about face-to-face contact. It's really about getting inside, understanding, helping the patient understand. There's a lot of patients in the hospitals that get discharged quickly. And not to anybody's fault. It's just they're inundated. They get inundated. And patients also see the light when they're ready after being in the hospital for 5 or 6 days. They want to get home. So the full story is not really happening there. 53.3% of our patients had medication errors in their home. That could be they didn't refill the med, they told the med they had, doc, they had it, they didn't have it, they had it in the wrong medication vial. Another thing we found with our COPD patients is spacer usage. Of our last 11, because we just had talked about this at our steering committee, the last 11 spacers for COPD patients, that's they take, obviously. 8 of 11 didn't have it or didn't know how to use it. Just in our last 11 patients. Overall health improvement so far, 14.3% out of our database. 12% or 11% got a better understanding of discharge instructions. Anxiety and depression, I thought that was kind of cool that improved by 9% or 8.1%. And this is the front page of what our, it's about a 17-page report with this, and it's really small. I'm sorry, I couldn't share it with you guys, so you guys share it out, but One of the things I find, this is our EMS survey report for the community paramedic patients, but 89.38 of responses to the standard questions had a rating of very good, and 100% of all responses were positive. So, and this is just some of the local press that we had in terms of getting good feedback. So, and then we were awarded with our Solano EMS agency, our national community best impact programs with us. And Doc already talked about the next step, so that's our program in a nutshell.
Beautiful, thank you.
Can I take questions?
So, can you hear me?
Yeah.
So I'm just trying to understand this a little bit more. So the theory is that by reconciling medication, looking at medication errors, there was a reduction in readmissions. I mean, a significant reduction in readmissions. So is that?
That's, I mean, we do a little bit more than that, but I'd say that, I mean, so some of these patients are train wrecks when we get them. We've had patients that don't have doctors, don't have cardiologists, that are heart failure patients that are getting off 7-day readmits because they came from out of state and they got released home because they didn't qualify for any services. And, I mean, some of these are just train wrecks, and I could go over that in length, but I know we're on a time crunch. But for the most part, we go home, we do all those assessments, the paramedics fill out forms, and then we realize that there's a medication error. We work with them, work with their doctor. All the patient visits are recorded. So in EMS, we do a per visit kind of documentation. So we could pick up the same patient 20 different times and not see all their history. The documentation system we use for this program is different. Every visit we have access to every medical record that the hospital shares with us, because we get the 30, 40-page discharge instruction. The paramedic gets access to all that. And so we're able to work with the personal medical doctor once we put up, or if they have one, and send all that information. So we kind of create a sharing of information between the hospital, between the medical doctor. Does that make sense? I'm sorry.
Yeah, no, it does. I guess I'm just, thinking, it's interesting that they didn't qualify for home health.
I
It's
thought the
interesting
same
that
thing too.
it wouldn't be an expanded role for home health, staff to take on this.
I agree.
I'm just, I'm very cognizant. I mean, I've actually just returning back to the U.S. after being an expatriate physician for 10, 13 years, and the thing that I find most astounding in the U.S. is, of course, what all of these changes, but also the fact that you've got so many people involved in one patient's care. And there's just, it's good, and I think there's a mixture of not so good in that, because it just creates this, what I always talk about is, who is that most responsible person? Who is, really at the core of, coordinating and providing that centralized care to that patient? And I'm just...
I can't say anything about home health in terms of, Dr. Backer said it perfect that we can interject to get them to home health. The patients that we see from North Bay have not qualified for home health. That assessment's done by North Bay's home health team, and they say these don't qualify, so that's part of their metrics. We don't get them with North Bay. So the patients that you're seeing per North Bay's team, they don't qualify for home health. So I'm not, my wife's occupational therapist, I get all that. I've had that battle at home with this, but we're not trying to, I don't think that we're doing, I don't think we're, and again, these patients are there to be served. They're just they're being lost because they're not the most complex, right? And they don't qualify all this attention. And then there's so many patients that need to be helped that, like we said earlier, it's this huge gap, right? And there's resources that can help. Sorry.
How much of the improvement would you, and I appreciate you might not be able to do this, ascribe to medication reconciliation versus patient education on their disease state versus patient education of the healthcare system and how they should work?
I think it all goes together. I think it all plays a role in each other. I personally, just what we see, I don't think that it's the meds that's the fix.
Mm-hmm.
I think it's them understanding. One of our first patients had, a box of, they went and got breakfast burritos at the local, because he was on a low sodium diet, so they didn't put salt on it. Well, I don't think you understand the term of what diet restrictions are, right? He had a box of donuts, and a breakfast burrito. But then it's understanding that the wrong meds, and then the guys, this isn't it, right? But they were perfectly fine. I mean, but they had ejection fraction of 30%, but she was ambulating, and all these different things going on. But they just didn't understand what dietary restrictions were. They thought it wasn't literally putting. They literally said that not putting salt on their meal. That's not what the doctor wants. So it's playing a role in that, right? And I think it's just eyes. I call it eyes on target, right? It's having the eyes on target, because when we talk to, and what's really interesting is our meetings with North Bay and their complex case management team, because the patients they're talking to, the patients that we see, and how what they're being told in the hospital and what's really happening in the home, it's not. It's just so they can get out.
Yeah, I've told that story.
Right.
So, I had a quick question for you. So, tremendous results, and congratulations on that effort. I know that's not easy to put together a program like that and to get results like that. Question I had was related to the difference. So I see your financial model is that the healthcare system is looking at their 30-day readmission penalties, and they're saying we're getting a CMS penalty for that, 3%, and therefore will reimburse you for a visit, $250 per visit, et cetera, for that. The area that you compete with is potentially the Visiting Nurse Association for that. What would be the advantages of a healthcare system paying you to see their patients in follow-up versus privately paying a visiting nurse group to go make the same visit? Is there any way that we could then compare visiting health nurse services versus yours in an individual who did not normally qualify for reimbursement for hospital nurse or visiting nurse services?
I think you have, it's a layered answer. It's not just as simple as like, okay, well, a private paramedic is cheaper than a private nurse. That's one, but that's not where we're going. You've got regulatory control, you have the home health issue, you have are we EMS, are we home health? So I mean, there's layers that kind of go into that. Dr. Backer said earlier, we have medics available, right? The whole goal that we see in AAA for us is better, faster, cheaper. That's how we talk, right? How do we deliver better care, quicker, and a more cost-effective rate?
Let me also take a shot at that because we aren't looking to go head-to-head with nurses. We're not looking to supplant or replace anyone in the healthcare system. We all know that there are huge gaps and cracks in our system, and lots of patients fall through. What I would say the advantage might be to paramedics are, again, their mobility, and they're 24/7, and they can more rapidly be deployed, whereas sometimes it takes up to a week to get home health going. Other systems may be able to do it in 72 hours, but it's not difficult for paramedics to get out there in the first 48 hours. And so, it's not, again, I wouldn't want to try to compare it, and I think that nurses have a higher level of training and skills, so you could say, well, they're going to do better. Well, maybe, but you still have to be able to get to the patient, and there is an affordability issue. Paramedics are not paid as much as nurses. So I would caution you not to look at the project in that way, because that's not what it's intended to do.
And you bring up another good point that I do want to say. What he said is that we see 20% of the patients that we've seen here are homeless, right? So they're at the street corner, they're under a bridge, they're in. I mean, you guys might see Vallejo on the news. We have some, some knife and gun clubs that are scary parks for people to go into, and we see patients in those areas. So, like my wife's home health, like I said, she has what they call black zones that they don't go into and see patients because of hostility. The vehicle, we don't send ambulances. We send a conspicuous vehicle, but it's got an ABL. They have a radio. They can immediately get out on. They have safety And I think you said it perfectly earlier, Doc, that we are trusted within the community. They do trust us. So when we come into a home, we're able to go into a bad area and we're not scared because we just ran a shooting on that street corner 2 weeks ago, right? So